So let's get started with, this is Module 6. This is our the Advanced Thoracic Dry Needling. This is Luke Haynes. I am the author and your presenter today under the Haynes Method, the Hybrid Dry Needling Certification, Haynes Method of NeuroMuscular Dry Needling. If you've made it to Module 6, then you're familiar with our layout, how we go through our content. At the end, there will be, for those who are looking to get certified and participate in our labs, there will be some post-module assignments that you'll want to complete and submit into the closed Facebook group, the Dry Needling Arena. So without further ado, let's just get started here. Again, this is our Advanced Thoracic. What we'll look at is our posterior scapular thoracic musculature that we will be dry needling. We'll look then at muscles on the anterior torso, and then we'll look at our tendons and ligaments, and then some regional or diagnosis protocols and one perineural protocols. If you're looking for an easier module, this is going to be the one. Not as many things to work on in the thoracic region. Most of those other things we'll see, say, in the shoulders and the hips a little bit later on. The spine segment, the lumbar and cervical, we'll have already covered. And so let's just move in here. Our supporting evidence piece here is a study done, and this came out in International Journal of Clinical Practice last year in March. It is a prediction model of rhomboid major and pleura depth based on anthropometric features to decrease the risk of pneumothorax during dry needling. Pneumothorax, especially when we talk about the thoracic spine, is our big enemy that we get concerned with anytime we're dry needling in that area. Definitely want to be certain of your landmarks, of your needle direction, needle placement, to ensure that we don't actually enter into the lung field. So a little background: most common adverse events associated with dry needling can be considered minor. Serious adverse events include induced pneumothorax, cannot be excluded, and safety instructions for reducing that risk of a pleura puncture are needed. Their objective is to investigate if anthropometric features can predict the rhomboid major muscle and pleura depth in a sample of healthy subjects to avoid the risk of pneumothorax during dry needling. So they looked at 59 healthy subjects, about half male, half female, involving a total of 236 measurements to calculate accuracy of a prediction model for both pleura and rhomboid depth, as assessed with ultrasound imaging based on sex, age, height, weight, BMI, breathing and chest circumference. Correlation matrix and a multiple linear regression analysis were used to detect those variables contributing significantly to the variance in both location. So the results were that men showed a greater height, weight, BMI, thorax circumference, and skin to rhomboid, rhomboid to pleura, and skin to pleura distances. No surprise there. Sex, BMI, and thorax circumference explain a little over half of the variance of the rhomboid and almost 70% of pleura depth limit. In general, inserting a maximum length of 19 millimeters is recommended to reach the deep limit of rhomboid major, decreasing the risk of passing through the pleura. The conclusion: the study identified that gender, BMI, and thorax circumference can predict both rhomboid and pleura depth as assessed with ultrasonography in healthy subjects. Our findings could assist clinicians in the needle length election in avoiding the risk of induced pneumothorax during dry needling. So what this study did was basically did ultrasound guided dry needling. What we're inferring from what they're saying is that they took a pure P to A, posterior to anterior needle placement to assess a proper needle depth. When we get to our rhomboids, we'll see that we're not going to go from a P to A position. We're actually going to go from medial to lateral, and use or attempt to use the medial scapular border as our backdrop, or just anterior to that. And we find that that is a pretty satisfactory way of eliminating those problems and decreasing the potential for pneumothorax. So we'll move on to our clinical decision-making piece. Here we talked in Module 5, introduced the 3D kinetic screen, or the 3KS. We went through that. Here we're going to add in a thoracic component with trunk rotation and some lumbar linear and diagonal rotation as well. So let's move directly into our video here. And again, as we talked about last time, I am actually the subject here. I definitely have some issues in my cervical spine. I've had previous right shoulder surgery and left clavicular fracture and ORIF. As a consequence of that, I try to change it, but I carry my left shoulder significantly higher than I do my right. And I point that out going through the stages of the 3KS screen. That's something that you want to evaluate. You see as I go in this diagonal position or movement with my neck, that left shoulder definitely raises up significantly higher. You can also notice that I have a fairly, it's an observable difference in range of motion in trunk rotation going from the left to the right. Going further left, I definitely have more rotation. And then just looking at it, cervical linear motion in a side view. As you do this 3KS screen, not a bad idea to look at different planes. Don't just look straight on, but look from the side as well. Look from the back if necessary. These dynamic movements can be very helpful in identifying where the problem is with the movement system. And that's ultimately what we're trying to do, is improve the movement, or our movement system. Again, the trunk rotation, just looking at it from a side view. When you do these rotation movements, definitely want to make sure that we give a nice, strong, tight, with a trunk rotation curve. What we're adding here is our lumbar linear motion. I'll say I also have some lumbar issues as well, and several exercises I go through to maintain that in a decent position. And similar, we'll add a three-dimensional piece to it, just a diagonal rotation, looking from side to side. So here we'll want to compare, how does that rotation compare with, and I'm just doing 5 repetitions there, how does that movement quantity compare here to the opposite side? So you look for quality of movement, quantity of movement, pain with movement, if there's any noted restriction in movement, and doing it three-dimensionally can certainly help isolate where your problem might be. All right. So we'll move into our, what I'm calling our junctional zone structures. Here we're going to start in our posterior scapulothoracic region. We've looked a little bit already at the latissimus as far as how to dry needle that, and the upper traps. We're going to review those again and then add in our middle and our lower traps. So in a moment we will walk through all of the three-dimensional anatomy. We probably have a reminder on our surface anatomy as well. So I'm going to, instead of reading all of these slides to you as in prior times, this will be available in the student portal with slides available there. But let's just go past this particular information and get to it in the video component. Actually, let me close that one out.
There. So we move on to the Latissimus. On the Latissimus, and let me zoom in a little bit here. For the origin of the Latissimus, it's going to be the spinous process of T7 to T12 and then L1 down to L5. Actually, let me hide or fade the traps. So again, similar to the trapezius, really broad muscle. It also has an attachment, or the origin via the thoracolumbar fascia down low, and then the 9th to the 12th ribs, and then probably most specifically down the iliac crest in this area, right there before the fibers of longissimus go beneath it or anterior to it to prevent it from attaching to the sacrum. Its insertion is on the humerus, so we look at an anterior view, and as I rotate around, it's going to insert just medial to the intertubercular groove. So that's the groove where the long head of the bicep sits as it comes over the humeral head, heading toward its attachment over here on the glenoid. So really an anterior attachment there, resulting in a really strong internal rotation effect with that. For the trapezius, and in this case, we'll target the upper trapezius. We have the fibers of the upper trapezius, fibers of the middle trapezius, and then finally the fibers of the ascending or the lower trapezius. Here we'll specify in this course the fibers of the upper trapezius. So the origin is the external occipital protuberance and the superior nuchal line of the occipital bone, the nuchal ligament, and the spinous process of the C7 vertebra. Insertion is into the posterior aspect of the lateral 1/3 of the clavicle and the acromion of the scapula. Its action is it elevates, retracts, and upwardly rotates the pectoral girdle at the acromioclavicular and sternoclavicular joints and extends and laterally flexes the head and neck. Its nerve supply is the accessory nerve and the anterior rami of the 3rd and 4th cervical nerves for the sensory component. And so as we move the muscle around, obviously a fairly robust muscle. As you can tell, the anterior, the superior aspect of the upper trap has quite a bit of muscular girth in that, and so and we'll talk about this in detail, but as we needle, that's that bulk of that girth that we're going to be looking for, the midpoint between the acromion and its occipital attachment, so right in there. For the middle trapezius, or the transverse part of the trapezius muscle, we see here its origin on the spinous processes of C7 through T4 vertebra. It inserts into the acromion of the scapula and the medial half of the spine of the scapula. Its action is it retracts the pectoral or the shoulder girdle at the acromioclavicular and the sternoclavicular joints. Its innervation, the accessory nerve, the anterior rami of the 3rd and 4th cervical nerves. And for the lower trapezius, or the ascending part of the trapezius muscle, its origin, the spinous processes of T5 through T12. Its insertion is into the medial half of the spine of the scapula. See its orientation there. And its action is it depresses, retracts, and upwardly rotates the pectoral girdle, or the shoulder girdle, at the AC and the SC joints. Innervation is by the nerve and the anterior rami of the 3rd and 4th cervical nerves.
All right, so we'll move into our surface anatomy next. And some of this will be a repeat from our introductory.
So the posterior scapulothoracic surface anatomy. Let's start first in finding T11, T12. Here, quite simply, we're going to find that bottom rib. We're going to follow it medially until we reach the spine. The spinous process cranial to rib is T11. The spinous process caudal is T12. So let's identify that. And I'm just going to palpate for the inner spinous space. And so here's the inferior aspect and the superior aspect. So here is 11, here is 12. Quite simply, we can now follow these ribs, these spinous processes, as we come more cranial. And in the thoracic spine, there can be quite a distance between. So rotated with the head, it's gonna, spinous process will rotate as well. And there's one. So you can follow those processes all the way up to get up to T1. Okay, so let's then talk about some reference points, both at T1 and at T3, T4. Before we do that, let's outline the margin of the scapula. So we'll look at the inferior border first, and then we will follow the medial border of the scapula up. You want to get all the way to the superior border. Superior border dive is a little bit deeper, so a little bit more challenging to palpate there. But there we have coming up and over. Another area we want to look at is the upper, or the more cranial, the more caudal piece of the spine of the scapula as it dives into the root of the spine of the scapula. Okay, we can follow the upper on out to the acromion itself. It's similar with the inferior border. So we talk about T1. The superior border of the superior angle of the scapula is basically going to sit, give or take, at the spinous process of T1. If we look at the root of the scapula, now this scapula is actually up just a little bit. However, it's going to sit between the spinous processes of T3 and T4. So that's a really nice way for us to locate that spinal level. If we drop down further, between T7, again, his scapula is sitting a little bit high, and I may have drawn it just a little high. It's basically going to correlate across in between spinous process of T7 and T8. So as we're palpating also, we come off of the spinous process. You can move laterally onto the transverse process. And then as you move out a little bit further onto the rib itself, you can actually locate the costo-transverse joint, where the rib comes and starts its articulation with the transverse process. So when we start at T1, talking about transverse processes in relation to the spinous process. At T1-2, if your finger is on the spinous process of T2,
then the transverse process is going to be 1 finger width cranial to that. So its transverse process is going to be sitting a little bit more superior. And that's for T1 and T2. If we're at T3, T4, then on that spinous process, now the transverse process is going to be 2 finger breadths above. And this all allows for the orientation of the spinous process in that particular vertebral segment. So we're at 1 finger breadth cranial, at 1 and 2, at 3 and 4, it's 2 finger breadths cranial, at 5 through 8, now we're up to 3 finger breadths cranial. At 9 and 10, we're back down to 2 finger breadths cranial. And then for 11 and 12, we're back to a single finger breadth cranial for the orientation of the transverse process to the spinous process. Okay, so let's get into our scapulothoracic treatment here. Let's look at latissimus. Again, upper, middle, and lower traps. Again, this is all information available, those slides in the mobile app, so you can review that information there. Let's jump straight in to the video piece. For the latissimus, the patient's going to be in the prone position. We're going to use a needle of 30 to 40 millimeters. Back drop, there is none. We're going to grasp the muscle near the humerus, pulling it away from the body using the fingers to block the rib cage, palpating for the thickest part of the muscle. We're going to needle posterior to anterior, medial to lateral, parallel with the rib cage, using the fingers to determine appropriate depth. Okay, so we'll look at the upper trapezius, which is a really common muscle that we treat any of that cervical thoracic, that CT junction business. That upper trapezius is a big player. For the upper trapezius, the patient again is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. There is no backdrop. We're going to palpate for the thickest aspect of the muscle belly. We're going to grasp the muscle between the thumb posteriorly and the fingers anteriorly, at least 1 thumb breadth above the supraclavicular margin to avoid the apex of the lung. We're going to insert the needle into the muscle in a posterior to anterior trajectory, using the fingers opposite the insertion point as a guide to determine needle depth. Okay, then we'll look at the middle and then the lower trapezius. For the middle trapezius, patient again in the prone position, needle length is going to be about 3 centimeters. There's no backdrop on this needle. We're going to use a pincher or a lumbrical grip medially and slightly superior to the root of the spine of the scapula to bunch up the fibers of the middle trapezius. We're going to needle from superior to inferior through the bulk of the muscle, using your fingers or your thumb as a backdrop. Okay, then down to the lower trapezius. So upper trapezius we needled, or middle trapezius we needled, let me come back to it, just superior to the root of the scapula, and then for lower we're going to come just a little bit lower to get into make a distinction between those two muscle groups, and to let us know, hey, yes, that trapezius really is that far distally. For the lower trapezius, a patient again is going to be in the prone position. Needle length is about 3 centimeters. There is no backdrop. We're going to use a pincher or a lumbrical grip midway between the root of the spine of the scapula and the inferior angle to bunch up the fibers of the lower trapezius. We're going to needle from superior to inferior directly into the muscle, or lateral to medial, threading through the bulk of the muscle using your fingers or the thumb as a backdrop. Okay, so let's move on into our next piece, our scapular specific muscles here, our levator scap, rhomboid major and minor, and then serratus posterior superior, and then the serratus anterior. So let's move on down to our 3D anatomy piece. Again, here's the information. That'll be in the slides available on the student portal. I'm not going to bore you with just reading this out to you right now, but let's go ahead and look at our 3D anatomy.
Taking a look here, levator scapulae, its origin, the transverse processes of C1, C2 vertebra, and the posterior tubercles of transverse processes of C3 and 4. Strips just coming off of the muscle itself as they come to their from their origins, and then ultimately their insertion to the superior angle of the scapula and the medial border of the scapula superior to the spine of the scapula. And so clinically we see levator scap involved significantly in both lateral cervical issues and in that scapulothoracic, cervical thoracic junction location. Can be involved with problems with inspiration as well. Then you have that upper trap, that tension, discomfort, upper levator scap, frequently a culprit there. Its action elevates and downwardly rotates the shoulder girdle at the AC and SC joints. It extends and laterally flexes the neck at the cervical vertebral joints. It's innervated by the anterior rami of the 3rd and 4th cervical nerves and the dorsal scapular nerve. For the rhomboid major muscle, its origin is the spinous processes of T through to T5, and it inserts into the medial border of the scapula inferior to the spine of the scapula. Its action is it retracts and downwardly rotates the shoulder girdle at the AC and SC joints. It's innervated by the dorsal scapular nerve C4, C5. The rhomboid minor, its origin is the nuchal ligament and the spinous processes of C7 and T1. Zoom in on that. And its insertion is into the medial border of the scapula, adjacent to the spine of the scapula. Its action is it retracts and downwardly rotates the shoulder girdle at the AC and SC joints, and it's innervated by the dorsal scapular nerve, C4 and C5. And the serratus posterior superior muscle, it is an origin on the nuchal ligament and the spinous processes of C7 through T3. It inserts into the external surfaces of the 2nd to the 5th ribs. Kind of zoom in. Oh, I zoomed too far. Zoom in here to their attachment to their insertion. Their action is elevation of the ribs at their costovertebral joints, and innervation is by the anterior rami of the 2nd to the 5th thoracic nerves. For serratus anterior, we have an origin on the external surfaces of the 1st to the 9th ribs, and it inserts into the medial border of the scapula. So origin fairly broad, and common insertion of subscapularis on that medial border of the scapula. Its action is it protracts and upwardly rotates the shoulder girdle at the AC and SC joints, and it's innervated by the long thoracic nerve C5, 6, and 7.
All right. So let's move into our treatment of levator, the rhomboids, and then the 2 serratus. So let's move into first here, levator. So levator is a really nice. So you're at the advanced content now. Levator is a real game changer when it comes to the CT junction. Anything in that area, avoiding. I like to refer to the levator as being similar in the upper body to the piriformis that we deal with in the lower body. So this was one definitely get very good and adept at kneeling levator. It'll pay off for you.
For the levator scapulae, the patient is in the prone position, hand behind back. Knee length is about 3 centimeters. There is no backdrop. With the patient's hand behind the back, we're going to use that pincher grip to grasp the musculature at the superior angle of the scapula. We're going to needle through the attachment onto the scapula from an inferior medial to a superior lateral direction along the plane of the rib cage, using your fingers as a backdrop.
And that's levator. Okay, let's move to rhomboid major and then rhomboid minor.
For the rhomboid major, patient again is going to be in the prone position. We'll end up with the hand behind the back. Knee length is going to be 3 centimeters, and the backdrop is going to be the medial border of the scapula. So with the patient's hand behind their back, we use a profundus grip to pull the medial border of the scapula away from the chest wall, and we're going to needle to the medial border, not anterior to the scapula, distal to the root of the scapula with periosteal pecking if necessary.
So in the study that we talked about earlier, you see we're actually threading through the fibers here of rhomboid major to needle that muscle, but we're going to the anterior surface of the scapula, or we could try to hit the lateral border or the medial border, but that's not really necessary. Guarantee safety if we do it that way, but you can catch it on the anterior surface of the scap as well. That way you get all of that muscle. But that's a nice change as opposed to kneeling P to A here down towards the lung field. Yes, you could needle 2 centimeters or slightly less than 2 centimeters that they found in that study. But I really like this approach a lot better. as you'll see in a little bit, and we get to the advanced shoulder as well. This is a similar approach that we're going to take for serratus anterior and for subscap as well when we get to the shoulder. So here you can get, honestly, you can get a threefer on this approach. Okay, and then rhomboid minor.
For the rhomboid minor, the patient again is in the prone position with the hand behind the back, a 3 centimeter needle with the medial border of the scapula as our backdrop. With the patient's hand behind their back, we're going to use a profundus grip again to pull the medial border of the scapula away from the chest wall. And we're going to needle to the medial border, not anterior to the scapula, at the root of the scapula with periosteal pecking if necessary.
Again, here you're in the advanced content. For absolute safety, needle to that medial border of the scapula. If you want to guarantee that you are clinically treating that muscle, aim for the anterior aspect of the scapula. But absolutely what you want to do is, number one, make sure that you're being safe with your approach. So if you don't have a comfort level, until you have a comfort level kneeling anterior to land on the anterior surface of that scapula, then make that medial border your target. Again, would rather be safe and ineffective than be unsafe. All right, so now we'll look at serratus posterior superior.
For the serratus posterior superior, patient again is going to be in the prone position. Needle length is only going to be about 2 centimeters. There is no backdrop here. We're going to palpate and identify the spinous processes of C7 to T3. We're going to needle from lateral to medial, slightly caudal, 2 finger breadths lateral from the spinous process. This is a superficial muscle and there is no backdrop.
Okay, and then our serratus anterior. Again, this is one that we look at fairly commonly in clinical application. We're going to look at 2 different approaches. One would be similar to what we just did for the rhomboid minor, going underneath or to the anterior surface of the scapula, sorry. Or alternatively, if we have a patient with decent body habitus and good muscle tone, if we can identify the rib and we have proficiency and are aware specifically of our needle depth, we can needle it onto the rib. But as you see it in red, do not attempt this if you cannot palpate the borders of the ribs, and even then, needle only 1 centimeter.
For the serratus anterior, position is going to be prone. We're going to have a needle length of about 3 centimeters. It could be a little bit more on this approach. The backdrop is going to be the anterior surface of the scapula. With the patient's hand behind their back, we're going to use a profundus grip to pull the medial border of the scapula away from the chest wall and needle to the anterior surface of the scapula with periosteal pecking if necessary. Alternatively, serratus anterior can also be needled directly onto the lateral ribs from 4 to 9 at the origin of the muscle. Do not attempt that if you cannot palpate the borders of the ribs, and needle only 1 centimeter.
So most common method here, the prone, hand behind back, kneeling onto the anterior surface of the scapula. Circumstances that I might consider kneeling onto the ribs if they're having a hard time getting hand behind back, or if I just just can't seem to get my needle placement to go to the anterior surface, then I might consider that alternative position on the side. Like such. Again, as you can tell, significant amount of that needle still out, and when I do it that way, I am looking for that rib as the backdrop, but if I would recommend, until you are comfortable with that lateral approach, again, only advance that needle 1 centimeter. Okay, then let's look at our spinal structures. Again, this is going to be very similar, slightly different in technique for Longissimus, Iliocostellus, and the multifidus. In the lumbar spine, we looked at multifidus and Longissimus together. Here we're going to look at Longissimus and Iliocostellus together, as they have deviated away from midline as they get higher into the thoracic spine. So let's move. That's all that information for your review. Let's look at our complete anatomy.
Let's look at multifidus first. In multifidus, again, we've looked at this before, but the origin, the posterior superior iliac spine, the dorsal surface of the sacrum, and the longissimus is sitting on top of it, so you can't see that, but the dorsum of the sacrum, the mammillary processes in the lumbar spine, the transverse processes in the thoracic spine, and then the lateral articular processes of C4 through C7. Inserts into the spinous processes of the lumbar, thoracic, and cervical vertebra all the way up to C2. Again, as we talked before, it does not continue on to C1. And again, it is the prime stabilizer in the spine, cervical, thoracic, and lumbar. Then we'll move from multifidus onto the spinalis. We have both a spinalis cervicis muscle and a thoracis. In the cervical spine, here our origin is the nuchal ligament and the spinous processes of C7 down to T2, so right through here. And then its insertion is into the spinous processes of C2, 3, and 4. So 2, 3, and 4. And again, action, and all of the erector spinae group, their action is going to be extending and either laterally flexing or rotating, in this case, the neck at the cervical vertebral joints. We move further distally into the thoracic spine, and then we'll see the spinalis thoracis. So here, the origin, the spinous processes of T11 down to L3. The insertion in the spinous processes of T2 down to T8. And again, extends, laterally flexes the trunk. So I've specifically mentioned the spinalis. As we are dry needling into our target tissue, most of the time going to be multifidus, we take that measurement that we talked about, 1 finger breadth lateral from the superolateral aspect of the spinous process. We're definitely going to go through spinalis as we're headed towards that laminar backdrop as we're trying to dry needle multifidus. And so that's spinalis. Let's look next at longissimus. 3 distinct muscles with longissimus. The biggest is longissimus thoracis. I still refer to it as lumborum in the lumbar spine, but its origin, spinous process of L1 through L5, in the dorsal surface of the sacrum and a little bit over to the iliac crest. It inserts into the transverse process of the lumbar and the thoracic vertebra, and the 2nd to the 12th ribs. As we start to get into the thoracic spine, you will start to see a little bit of a lateral migration away from midline of the longissimus thoracis. So we move a little bit more into the cervical region. Then we find 2 more smaller structures. One is the longissimus cervicis, because it attaches into the cervical spine, and medial to that is the longissimus capitis, because it's attaching to the skull. So the longissimus capitis, here the origin is the transverse process of C4 down to T4, and it inserts into the mastoid process, get a little closer view there, of the temporal bone. We look laterally at the longissimus surfaces. Here, its origin is going to be the transverse process of T1 to T6, and then inserts into the posterior tubercles of the transverse processes of C2 through C6. And so just lateral to the articular pillar. We will find when we get to the advanced cervical piece, we also have some correlation here with the scalenes, and this is where we start to look at using the lateral, the articular pillar, especially at a certain level, for dry needling a large number of these muscles all at one time, including some of the scaling. And so that's longissimus. Let's look lastly at Iliocostellus. We do have Iliocostellus Lumborum. Again, its origin is the iliac crest and the posterolateral aspect of the sacrum. It inserts into the transverse processes of L1 through L4, and then the angles of the 5th to the 10th ribs. As we get to the 10th, 11th rib, we're going to see that Iliocostellus move a little bit more lateral with respect to this paravertebral group. And partly that is because this is also the location where Iliocostellus thoracis originates and takes off between Iliocostellus lumborum and longissimus thoracis. Here, Iliocostellus thoracis, the origin is the angle of the 7th to the 12th ribs. It inserts into the angles of the 1st to the 6th ribs. So it is possible, and we will address this when we get to the needling of this. It is possible to needle into that angle. It is a much higher skilled needling concept, simply because of this danger zone of the intercostal space and the potential for entering the lung field. So there we have the posterior scapulothoracic 3D anatomy.
All right, so as far as treatment, let's get right into, we'll do the multifidus and the rotatories. I didn't go into the 3D anatomy of the rotatories. There's basically two of them. Very small, probably not really related to anything clinically. However, if it is, when we treat multifidus, we are going to have an interface there with that rotatories. Then again, there's spinalis, longissimus, iliocostellus, and the interspinalis. So let's come down, start with spinalis, rotatories, and multifidus. For the thoracic spinalis, the rotatories, and the multifidus, the patient's going to be in the prone position. Knee length is going to be 20 to 40 millimeters. Backdrop here is going to be the thoracic lamina. Precautions here, the lung field, the medial branch, the posterior ramus of T6 and T7, anterior ramus of T8, 8th posterior intercostal artery in the vein. We're going to palpate for the spinous process of T7 at the level of the inferior angle of the scapula. Needle placement is 1 finger breadth lateral from the spinous process. Angulation at 15 to 20 degrees caudal and medial. Okay, longissimus and iliocostellus. Again, because they're now so much closer, we're going to look at those together. For
For the thoracic longissimus and iliocostellus, again, patient's going to be in the prone position. Needle length will be about 30 millimeters. There is no backdrop. We're going to grasp the lateral border of the rectus spinae grip with a profundus grip. We're going to apply firm pressure, splay the index and middle finger. We're going to needle 3 to 4 finger breadths lateral to the spinous process of T7 with a 50 to 60 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebral lamina with no backdrop.
Okay, again, interspinalis, we want to be able to needle this in the event that there is an interspinalis issue, a completely center or midline issue, very similar to lumbar, where we'll go approximately 15 to 20 degrees anterior and superior. We want to keep that needle depth less than 20 millimeters to avoid the spinal canal.
For the interspinalis, position is going to be prone again. Needle length is less than 20 millimeters. There is no backdrop here. We're going to palpate to find the interspinous space between T7 and T8. When dealing with the spine, this will be the only time that you will have a superior needle angulation. Here it's going to be 15 to 20 degrees anterior, superior, perpendicular to the skin surface. Again, caution for the depth, less than 20 millimeters to avoid the spinal canal.
And here in the thoracic spine, definitely much easier to get in between the spinous processes than we did, say, when we were down at L3, L4, L4, L5. Just a lot more space for us to get in between here. Okay, now let's move on to the anterior torso. Here we'll look at Pec Major and Minor, subclavius, and then Rectus Abdominis, the Transverse Abdominis, and then external and internal obliques. So let's move through here. Let's get all the way to our 3D anatomy and discuss it there.
All right, so let's move anterior. And let's talk Pec Major, which we've looked at in previous material, but its origin, the anterior aspects, the medial half of the clavicle, the manubrium, and the body of the sternum, and the superior 6 costal cartilage. It inserts into the crest of the greater tubercle of the humerus. Okay, just a little bit further, we find deltoid, if you recall, Latissimus comes up and attaches anterior to Pec Major. Clavicular fibers and sternal fibers. There are times, so in a moment we're going to dry needle this thing right here, very similar to Latissimus. We're going to reach in, grab that muscle and needle through that muscle fiber. Occasionally we do find that we need to get more into the inferior or the sternal fibers as they course this way. But as a good general rule, we're going to needle right here. We move over to Pec Minor. So on Pec Minor, origin, the anterior ends of the 3rd, 4th, and 5th ribs. And then its insertion, we'll look here, is into the coracoid process of the scapula. And notably, it is on the medial surface. of the coracoid. So when you're palpating your patient and looking for landmarks, if there's say a shoulder problem going on, this coracoid process is going to be tender. It is a challenge or tender to palpate in an asymptomatic person at times. But if we want to, and we'll talk about how to needle it, important to note that it's off of the medial aspect, not on the edge or the anterior piece of the acromion itself. Its action, it protracts and downwardly rotates the shoulder girdle and is innervated by the medial and lateral pectoral nerves. So we move into the rectus abdominis, which is absent. Let's move this out of the way. We need the rectus abdominis. All right, let me hide that. Okay, so let me hide that. Well, let's start laterally with the obliques. So external oblique, its origin, the external surfaces and inferior borders of the 5th to the 12th ribs. So interestingly, here we have Serratus Anterior. And you'll notice a very close similarity to where Serratus Anterior ends and the external abdominal oblique ends. It inserts into the anterior superior iliac spine, down the inguinal ligament, into the pubic crest, the pubic tubercle, and then ultimately into the linea alba. Okay, we look at our internal oblique. Here our origin is the thoracolumbar fascia, which for some reason is hidden. Anyway, the thoracolumbar fascia that sits in this area. Also the iliac crest and the inguinal ligament. Okay, so right this entire crest at the ilium. It inserts into the inferior margins of the 10th to the 12th ribs, the adjacent costal cartilage, the linea alba, and the pecten pubis. So we have both of these structures terminating into the linea alba, which we will talk about just a little bit later. I'm going to hide that to bring us to, let's go ahead and let me do rectus abdominis next. I'm going to fade the transversus abdominis so that we see the fibers of rectus abdominis. Yes, from time to time we do have patients with abdominal midline discomfort. These segments can actually have low-grade spasm, muscle tension, neuromuscular dysfunction, and so these are needleable. Origin, the pubic crest and the pubic symphysis, and it inserts into the xiphoid process the costal cartilage of the 5th to the 7th ribs. So right along this path right here. Its action, it flexes the trunk, compresses and provides structural support to the adjacent abdominal structures. And so now let's bring transversus abdominis back. Here I'm going to go ahead actually and hide rectus abdominis. Okay, so bring that back. The transversus abdominis. The origin here is the costal cartilage of the 7th to the 12th ribs, and the thoracolumbar fascia, the iliac crest, and the inguinal ligament. So a broad origin. It's going to attach into the linea alba, the pubic crest, and the pecten pubis. So as you can see, all of these structures do a significant job on their attachment to the linea alba. All right, and so we have one more, the subclavius. Let's look here. So the subclavius is a little small muscle. Its origin, superior surface of the costal end of the first rib and the adjacent first costal cartilage. So we're just attaching just right in this area. It inserts to the inferior surface of the middle 1/3 of the clavicle, and its action is stabilizing the clavicle, and so subclavius. All right.
Okay, so for our treatment, we'll again look at our Pec Major, Minor, Subclavius, and then our muscles of our torso, Rectus Abdominis, Transversus Abdominis, external and internal obliques. Pectoralis Major, the patient is going to be in the supine position. Needle length will be from 40 to 60 millimeters based on patient's habitus. Backdrop, there's going to be no backdrop in this situation. Again, with the patient in the supine position, shoulder will be abducted to 90 degrees and then externally rotated. In that position, we're going to grasp the muscle with the fingers in the axilla, blocking the rib cage, palpating between the thumb to locate the thickest aspect of the muscle. We're going to pull the muscle away from the rib cage, and we're going to needle medial to lateral, parallel with the rib cage, using the fingers as a backdrop to determine appropriate depth. Caution here to avoid the lung field. Okay, that's major and to minor. For pectoralis minor, patient again is going to be in the supine position. Needle length here is going to be 2 to 3 centimeters. Backdrop is going to be none or ribs 3, 4, and 5, and we'll talk about that in a moment. Precautions here, definitely the lung field, the brachial plexus, and the neurovascular bundle. So there are 3 possible needling sites. One is going to be at the tenoosseous junction, just medial to the coracoid process, needling anterior posterior for 2 centimeters. The second, we're going to place our fingers into the axilla and the thumb on the anterior chest wall, pulling the Pec Minor up and away from the chest wall and needling tangentially to the chest wall into the belly of Pec Minor. The preposition can be uncomfortable to the patient, but it's required to ensure we're hitting the Pec Minor. The third one, do not attempt this if you cannot palpate the course of the ribs 3, 4, and 5. Pec Minor attaches approximately 2 finger breadths lateral to the costochondral junction. And it can be needled directly onto the rib about 4 finger breadths from the costochondral junction. Consider a midpoint between the nipple and the clavicle. Again, this is one you probably won't do unless you have a significant ability to palpate those ribs. Again, similar to Pec Major, for Pec Minor, because we're trying to get those fingers into the axilla far enough, almost approximating the coracoid process. So your palpation, your prep work can be more uncomfortable than the actual needle itself. So this second approach, we're going to go off the medial aspect of the coracoid process. That's the attachment side. So I don't even demonstrate off of ribs 2, 3, 4, and 5. I've done it a handful of times. Really, these other approaches are much better. But that third option is there just as an option for you. If you're dealing with a Pec Minor issue, odds are there's going to be some other things going on in and around that coracoid process. So probably clinically, I'm probably going to go after Pec Minor there at the coracoid process first, and then look at that other axillary approach or hand position approach second. Okay, and then subclavius. For the subclavius, the patient again is going to be in the supine position. Needle length will be 2 to 3 centimeters at most. The backdrop here is going to be the undersurface of the clavicle. We're going to use a profundus grip at the inferior margin of the midpoint of the clavicle, and we're going to needle from inferior to butt onto the undersurface of the clavicle. So we find that midpoint, use that profundus grip so we can identify this margin, and then you're going to needle onto the undersurface there of the clavicle. Again, we're getting very close to some danger zones, so if you don't find the undersurface of the clavicle as your backdrop, don't keep wandering around with your needle. You don't want to end up going anterior into the lung field or into the neurovascular structures that are just sitting right there. Okay, then rectus abdominis.
For the rectus abdominis, the patient is obviously going to be in the supine position. Here, our needle length is going to be 2 to 3 centimeters. The abdominal contents sit just posterior to the rectus abdominis, so caution in advancing the needle beyond what the subject's body habitus will accommodate. A patient with minimal body fat will require shorter needle depth. So here the backdrop is none. And again, precautions here for the abdominal contents. Two places of needling here. First, let's start at the costal cartilage of the 6th and 7th ribs, lateral to the xiphoid process. We're going to needle perpendicular through the rectus abdominis to the costal cartilage, which will feel kind of spongy. On the second needling approach, in the other regions of the rectus, we'll needle in an oblique angle, and we're just going to sense the tissue levels. We do not want to pass through the rectus and enter the abdominal cavity.
And there you can see a nice oblique angle entering into that lower region. And the rectus abdominis can be, as you develop your skill set with what dry needling can have an impact on. You will find from time to time that rectus abdominis is actually an issue with some people, and needle it fairly frequently. And then we'll look at the transversus abdominis, the external obliques, and the internal obliques. And so here we're going to actually needle these as a single muscular unit. We're going to do it just cranial from the iliac crest, so they'll be in that side-lying position. The challenge here is to make sure if you've got a big, heavy person, to make sure that you're actually getting into that muscle without compromising going into the abdominal contents.
For the transverse abdominis, the external obliques and the internal obliques, we're going to needle those all as a single unit. Here your patient can either be in the supine position. I prefer the side-lying position. Above the ASIS, we're going to grasp the abdominal musculature with a lumbrical grip, and we're going to pull away from the body. We're going to needle in an anterior to posterior angulation using your fingers or your thumb as a backdrop.
So now let's move on to our tendons and ligaments. Thinking cervical, I don't think we had any tendons and ligaments that we dealt with in our last module. But here we'll start to get into some. Now it's interesting, as we move from this point forward, the tendons and ligaments become more and more interrelated into the module. We just get so much more once we get into the shoulder, especially out to the wrist and hand and the ankle, foot, just lots of tendons and ligaments. Here we're just going to look at 5 for this piece. And this information is all available. We will go through this if it doesn't include this in our 3D approach, then I'll come back to this. But first is going to be the radiate sternocostal ligaments. And then our costal cartilage, well, bear with me. Okay, here we go to our treatment piece. So first, the radiate sternocostal ligaments.
For the radiate sternocostal ligaments position, if the patient's going to be in the supine position, knee length is going to be 1.5 centimeters. Backdrop is going to be down to the sternum. Precautions here: the anterior cutaneous branch of the anterior ramus of the segmental nerves, the perforating branches of the internal thoracic artery and internal thoracic vein, as well as the lung field. Here we're going to palpate along the lateral border of the sternum to appreciate the bump at each of the sternocostal notches. Needling will be in the anterior to posterior direction onto the sternum, 1 finger breadth medial to the sternocostal bump.
And so here we could be looking at something similar to costochondritis. A few reasons why you might needle into this, the radiate sternocostal ligament, and our next one, which is the costal cartilage itself. We don't do it that often, but if there is some of that midline anterior chest pain, if you've ruled out any other significant problems, then this could be a good treatment option. Okay, and then next will be that costal cartilage. So we're gonna use that that costochondral bump that we looked at. We went about a finger breadth medial to that for the radiate ligaments. Here we're going to go finger breadth laterally.
The costal cartilage. Here the patient's going to be in the supine position. Needle length is 1.5 centimeters, and the backdrop is the costal cartilage, and you do not want to go deeper than that. Precautions: the anterior cutaneous branch of the anterior ramus of the segmental nerves, the perforating branches of the internal thoracic artery and the internal thoracic vein, as well as the lung field. Here we're going to palpate the costochondral bump at the notch. We're going to move laterally 1 finger breadth, where we'll bracket the costal cartilage with the fingers butted up against it. We're going to needle in an anterior posterior direction. This structure is superficial, and you do not needle through to a backdrop. The cartilage will feel spongy, and do not needle through. If you cannot identify the costal cartilage, do not attempt to needle this structure.
One additional area of caution here, similar when needling pectoralis. If you are dealing with a person who may have breast augmentation, you definitely want to have this conversation about if you feel like this is a clinically appropriate area to needle. Just have that conversation with them. Talk to them about their comfort level with needling in that area. And then you clinically have to make sure that you have a comfort level if there is enhancement. On this medial for the ligaments on the sternum, I personally would probably, if there's augmentation, I probably would not needle in that area. Much more easy to needle laterally, say in the pecs, and avoid any of that than here in this midline. Okay, then we'll have the anterior sternoclavicular joint. Later we'll get to the acromioclavicular. We'll do that in the shoulder, but here we'll look at the anterior SC joint ligament.
But for the anterior SC or sternoclavicular joint ligament, Patient again in the supine position, needle length being 1.5 centimeters and backdrop being none. Do not needle past the posterior SC joint ligament. Precautions here: the anterior cutaneous branch of the anterior ramus of the segmental nerve, the perforating branch of the internal thoracic artery, the internal thoracic vein, the lung field, the brachiocephalic trunks, and the supraclavicular nerves. Here identified there. We'll try that. We'll palpate medially along the clavicle until you reach the drop-off at the manubrium, and we'll palpate for the inferior border. At the medial inferior border of the SC joint, we'll needle in a superior and posterior direction of approximately 45 degrees with no backdrop. Again, no more than 1.5 centimeters.
And then the Linea Alba. And so we will come down, talk about this just a little bit. Actually, I'm going to come way up, talk about the Linea Alba a little bit. So when and where and why would we dry needle the Linea Alba? I mean, a number of potential reasons. We don't do it frequently, but it can be done. With the Linea Alba, one thing we want to be cautious of is if there's a diastasis recti. If that's happening, and basically what that means is when there is, just read this for good information, a diastasis recti of the Linea Alba occurs when there is a tear which increases the distance between the rectus abdominis, most common postpartum from overstretching. Function of the Linea Alba is to maintain the abdominal muscles at a certain proximity to each other. In the case of a long-lasting increased intra-abdominal pressure, the Linea Alba widens, and this can be considered normal up to a width of 15 millimeters at the xiphoid, up to 22 millimeters at the reference point 3 centimeters above the umbilicus, and up to 16 millimeters at a reference point 2 centimeters below the umbilicus in nulliparous women. And this came from study in 2009. But you will find people that have significantly wider problems there. If it's a problem with the diastasis recti, probably I won't needle into that unless so many other things have been attempted. If I am going to needle into that, I'm going to be extremely cautious. Again, that ligament has already stretched and thinned, so there is reason to think that we could needle it and proliferate some restructure of that matrix formation in the collagen, but we certainly don't want to create more of an issue by needling at a depth beyond which we should. So just use clinical judgment on your depth there. Okay, let me come back to it here.
For the Linea Alba, the patient here is going to be supine with a needle length of no more than 1.5 centimeters. There is no backdrop. Precaution here: if there is diastasis recti present, proceed with extreme caution, as the abdominal contents can be very superficial in those locations. For the procedure, with the subject in supine, the knees bent and the feet planted, we'll lift the head toward the xiphoid to assess the width of the Linea Alba, to palpate for the diastasis recti. Location of needling will be in midline, less than 1 centimeter penetration in the area of symptomatic complaint. We'll rule out other sources of pain prior to needling the Linea Alba.
Then lastly, the inguinal ligament. Inguinal ligament can present as a clinical problem. It's not common, but we do have it there, and it's so close to where we needle sartorius that I include it in the event that we are dealing with something significant there. We're just going to be one finger breadth medial from sartorius along the line of the inguinal ligament.
For the inguinal ligament, position here is going to be supine with a needle length of 1.5 centimeters, and there is no backdrop. The precautions here, the anterior cutaneous branch of the iliohypogastric nerve, the lateral femoral cutaneous nerve, the ilioinguinal nerve, superficial circumflex artery and vein, and then, given the location, any of the lower abdominal contents. So the procedure, we're going to palpate the ASIS and then the origin of the sartorius as the subject lifts the leg off the table. Needle location is going to be 1 finger breadths medial from the sartorius along the line of the inguinal ligament. So with this attachment, we'll needle for inguinal ligament right in this area.
So you can test for sartorius, which we just did there, and then move 1 finger breadth further medially. Okay, now onto our regional, our diagnosis protocols, and we'll finish with our perineural protocol. We only have one up high that we look at. Here we're going to look at just pain related to problems with CT junction, the ST junction, low at the thoracolumbar junction, and then just general thoracic pain, and then a thoracic outlet. And whenever we get to the shoulder, we'll look at a sick scapula, our scapular dyskinesis, snapping scapula, and a wing scapula. But this could be presented here, but we're going to wait and do that all when we deal with the shoulder. So for 1 second here. All right. So for our CT junction, again, in the app, these should be loaded in there. If not, they will be shortly. I'm working on updating that to an iOS or over to Android instead of it being a mobile app. So anyway, I digress. We'll look at our primary locations, which again, we are always going to start with these things. So at our CT junction, we want to look at first the upper traps, and then that piece from the introductory adjacent to the spinous process of C6 and the spinous process of T4 to get all of those. Our second, we'll look at middle traps, and then anywhere segmentally from the spinous process of C5 down to T6. We'll add in levator and rhomboid minor. And then lastly, we would look at lower trapezius, serratus superior, posterior, rhomboid major, serratus anterior, and subscap. So basically, everything up and down the chain there, adjacent to the medial border of the scapula. And for that, we'll look at segmentally anywhere for C5 to T6 for our proximal spinal segmental locations.
For the cervicothoracic junction, patient position here will be prone. Target structures will be the cervical and thoracic erect or spiny group, as well as the scapulothoracic musculature. Electrical stimulation, again, 20 minutes from a burst frequency of 3 up to 75 to 100 hertz. The primary locations here, we'll look at the upper trapezius, and then those muscles adjacent to the spinous process of C6 and the spinous process of T4. In needling approach, we'll take 1 finger breadth lateral to the spinous process and needle medially and slightly inferiorly down to the lamina of the vertebra. We move further into the secondary locations. So here we'll look at the middle trapezius segmentally. At the spinous process, anywhere from C5 all the way to T6, we'll talk about levator scap, and then rhomboid major. Again, those secondary needle locations or target structures that we want to needle. From a tertiary standpoint, our third layer, we'll look at, let me see if I can bring, it's sitting right there, the lower trapezius, serratus superior posterior sits anterior to or deep to the rhomboids. Again, rhomboid major, and then serratus anterior, and then subscap on the anterior surface of the scapula itself. Lastly, we'll get down to some proximal spinal segmental locations, and again, anywhere from C5 all the way down to the mid-thoracic region. Good needling location for local segmental tri-needling approach. So the regional diagnosis specific protocol for the cervical thoracic or the CT junction. Here the patient is going to be in the prone position, and our target structures are going to be the cervical and thoracic rectus spinae muscle group and the scapulothoracic muscles. So who would be the proper candidate for this protocol? Well, if you have a mid to upper cervical region that didn't extend down below C7 or T1, obviously you could stay elevated. But if you're going through your 3KS, your three-dimensional kinetic screen, and you do find some of that pain has traveled down into the scapular region or below the level of C7, then it would be appropriate to go ahead and introduce this CT junction regional diagnosis specific protocol. Here, our primary locations are going to be upper traps adjacent to the spinous process of C6 and T4. That'd be those muscle groupings that we did an introductory cervical spine that will accommodate all of that erector spinae group in the cervical spine. Our secondary locations would be the middle trapezius, and then segmentally the spinous process of anywhere from C5 down to T6. Secondary, again, we had to include the levator scap, rhomboid minor, and then getting to our tertiary locations would be lower trap, serratus superior posterior, rhomboid major, serratus anterior, and then subscapularis. But let's look into our upper trapezius, our primary locations first, and I'm going to bring this screen on over. So we've got these two right here, and so let's pull out a tool. I'm going to use a 3D pen here. So first off, we recall we want to hit, again, upper trapezius. We're just going to find that midpoint between the acromion and the base of the neck. So right about here will be our target. Let me go ahead and clear that. Will be about here. Then we want to be adjacent to C6. So here is C7, the spinous process C7. So C6, we could be one finger breadth to either side there. And then also we had gone through T4, one finger breadth lateral from the spinous process of T4. And so that would be our primary needle location. So we'll move out of that. Let's come back. Our secondary locations, our middle trap, segmentally again from spinous process, C5 down to T6, the levator scap and the rhomboid minor. You can see those three locations there. And then for rhomboid minor, so that would look like this. Let me come up, and we'll look at on the right side since that area is dulled a little bit or faded. So again, our 3D pen, we would look at levator scap. So that would be through that area. We would definitely want rhomboid minor. We'll have serratus anterior superior. We'll catch right off the spinous process, and levator scap. Oh, the middle trap. That's right. And then the middle trap, which we will catch right in here, right around the spine of the scapula. I actually could have brought Rhomboid Minor up just a little bit. As you can see, Serratus Superior, Inferior, Serratus Posterior, Superior is also, we're going to kneel that in line with Rhomboid Minor. So those three locations for our secondary locations. And then we'll come down and look again at our tertiary. Here we'll have the lower trapezius, Serratus Superior. Well, let me come back. Rhomboid, levator, middle trap, not so it's in our tertiary that we have the Serratus Superior Posterior. We can also catch Rhomboid Minor in that same area at its insertion. But here, the lower trapezius, which we'll catch down really low, the Serratus Posterior, Superior Posterior, Rhomboid Major, which we'll catch right here, and then Serratus Anterior and subscap will needle from the posterior aspect onto the anterior surface of the scapula. And so those five right in a row right there, again, being in a prone position, we'll be able to catch those nice and easily. Catch my pin. The lower trap, we can come up a little bit higher and catch Serratus Anterior, subscap, Rhomboid Major, and then Serratus Posterior, Superior. So Rhomboid Major. So the needle inclination for here, we're going to be threading through the trap. We'll need to, for rhomboid, we'll need to butt up against the medial border of the scapula to get into that. Again, with the needle placement for Serratus Anterior and subscap, it'll be similar to what we're doing for the Rhomboid Major. Rhomboid Major, if at all possible, we want to peck onto this medial border periosteum. For Serratus Anterior and subscap, we want to move anterior into the anterior aspect of the scapula. And so actually we want needle placement to terminate right about here, but on the anterior aspect. And so that is the tertiary level for the CT junction.
All right. So we'll move on to the ST, or the scapulo-thoracic junction. Now you're going to notice that there's a lot of carryover between the CT and the scapulo-thoracic junction. You'll find that you probably treat them all fairly similarly, but few different changes in each one.
For the scapulothoracic dry needling protocol, the patient will be in the prone position. Our target structures will be the scapular stabilizers. For electrical stimulation, we can look at up to 20 minutes. Stim, recommended burst frequency 3 up to 100 hertz. Our primary structures will be the upper, middle, and lower trapezius, the rhomboid major, and the rhomboid minor. Our secondary locations will be the levator scapulae and the serratus anterior, and then the tertiary locations would be subscapularis and latissimus dorsi. The proximal spinal segmental locations would be C4, C5, C6, and C7. Okay, let's look at the scapulothoracic, or the ST junction, the dry needling protocol. This is the regional diagnosis specific protocol. Patient here is going to be in the prone position, and here our target structures are scapular stabilizers. And so when would we want to use the ST junction? Well, anytime we're dealing with any of this upper thoracic laterally towards the scapular border, this is something you're going to feel out as you're going through your 3KS, your dynamic movement assessment. Movement in the shoulder blade area should represent some sort of a dysfunction, whether it's a limitation of movement, whether it's a pain issue. We should see that there, and that would make this appropriate for this treatment protocol.
Primary locations are going to be the trapezius and the rhomboids, secondary levator scap, serratus anterior, and then tertiary the subscap and latissimus. So you can see we just have a little crescent of structures that we're going to needle all around the shoulder blade itself. So I'm going to move this out of the way and move this up. So let's come down, let's look. Let me undo that. I don't need to mark on it yet. Okay, so we'll look at the scapular border here. Okay, so the first is going to be our trapezius and our rhomboids. So let's take a look here. Let me get rid of that. Too many things happening. All right, down to my pen. So the trapezius, we'll look at the upper trapezius. We'll catch the fibers of the middle trapezius, and then we'll catch them down low as well. So we'll catch the trapezius, and then we want to catch rhomboids as well. So on the middle and lower trapezius, the needle here is going to be threaded through this musculature. So otherwise, it would be at a great location to go ahead and hit the rhomboids. In this particular case, you could travel through the trapezius and into the rhomboid, both minor and major, at the same time. However, you're going to get less surface area of the trapezius if you're not threaded through that. So I would recommend a threading through upper, middle, lower trapezius. And then on the rhomboids, minor and major, more of from midline towards the scapular border itself. Again, on rhomboids, our goal is to try to tap or to peck onto the medial border of the scapula, both here in the upper aspect for minor and then lower for major. So our second location, let me go ahead and clear those. Secondary locations are going to be the levator scap. So we're going to catch right here. And again, depending on preference and patient position, you can needle preferably superior to inferior, although it can be inferior to superior. Again, patient, therapist, position dependent there. And then we also want to catch the serratus anterior. So here we're going to put hand behind the back. We're going to wing that medial border up a little bit. Then we can advance that needle from medial to lateral to land on the anterior surface of the scapula. And those are our secondary locations. Then we move on to, let me clear those. We'll move on to our tertiary location, which here we're going to look at subscapularis and latissimus dorsi. So when we came in just a moment ago for serratus anterior, we actually will have hit subscap there. So that's another one of the two first we get. And actually in this case, if we're coming in right at or above the spine of the scapula, we're also going to get rhomboid minor. But for our tertiary location, the plan is subscapularis, and then further laterally, we would catch the latissimus. Let me go ahead and pull the pin up. Right on the lateral aspect as well. So that would be our tertiary for our scapulothoracic junction pain. Okay, now we'll drop down lower to the TL junction. Some of this we won't, like we haven't covered straight. Well, no, we have covered serratus posterior inferior. No, we covered that in the advanced lumbar on our next. So some of this you won't actually have the content until we start into the next module. But we'll cover it regardless, and we'll duplicate it for that module
The
as well.
protocol for dry needling the thoracolumbar region. Here the patient will be in the prone position. Our primary locations will be multifidus longissimus thoracis and Iliocostellus thoracis. These can all be accomplished by two separate needle placements at each spinal segment, at a segmental level. And which segmental level is just determined on patient symptomology. We move to our secondary locations, and here we'll look at latissimus and the lower trapezius. So coming more to that TL junction right there of the lower traps, and latissimus, big broad muscles that contribute to that TL junction. And then finally moving down to our tertiary locations, and I will move to our location here. All right, so as we move, I'm going to look at two different sides. Our obliques, internal and external obliques, and then transversus abdominis, definitely contributors to issues related to TL junction. And then further, and I've gone a little bit deeper here, we'll look at quadratus lumborum and the psoas major. One could say iliacus may treat them similarly, but those are the structures identified, and we would look at treating for pain in the TL junction. Okay, so the regional protocol for the TL, or the thoracolumbar junction. Here, the dry needling protocol, patient's going to be in the prone position. And this is going to be any of those pain patterns that you see from middle to lower thoracic spine all the way down to, let's say, the level of the iliac crest. So very frequently, and when we do treat quote unquote back pain, we are going to be dealing with more of a TL junction, especially if it comes up into that lumbar spine towards the thoracic junction. Here, our primary dry needle locations are going to be the multifidus, the longissimus, and iliocostellus. Our secondary locations, we're going to go ahead and get latissimus and the lower trapezius. And then for our tertiary locations, we'll hit transversus abdominis, internal, external obliques, the serratus posterior, superior, QL, and psoas major. So let me move this out of the way. Let's bring up our fella here. All right, so first thing we're going to look at, our primary locations will be multifidus. Let me bring up my pen. 3D black. So multifidus. Let's say we wanted to catch, what we know here is 4, 3, 2, 1. Let's say we wanted to needle. Let's zoom in a little bit here. So again, we know 5, 4, 3, 2, 1. The base terminal end of the trapezius. Let's catch our tool again. So 3D. Again, we want to catch multifidus, so we'll come up. Let's come up a segment above. So 1 finger breadth lateral. Okay, we'll do above, and let me change that to black. That's much easier to see. Okay, we are 3D there. Wonderful. So there's multifidus at T12. We'll drop down a level and catch T1. We can take that, or L1, and we can take that all the way down segmentally as we need to. For our longissimus and thoracis, longissimus will be needling as it sits right here. We'll needle through that in the lumbar spine. As we get into the thoracic, it's going to veer a little bit lateral, so we'll have to make a different approach. But here, we should be getting into that. For our iliocostellus, then we're going to have to come from this lateral position, and here our needle will be oriented from lateral to medial, fairly superficial, so we don't get too deep, but still catch all of the fibers of the iliocostellus here. So that's our primary locations. Our secondary locations, let me clear our business there, is going to be the latissimus and the lower trapezius, lower traps. We will just simply catch those. Let me get my pen. The lower traps we can catch right here. We'll just grab those with a pincher grip, lumbrical grip possibly, and then thread across this direction. And then for, that's lower trap for latissimus, where we're just going to put our hand into that bulk of the muscle in the axilla, and in about this location we will needle away from midline from medial to lateral, making sure that we don't get into that rib cage. So let's clear that. We'll get to our tertiary location, and here, different locations to do the transversus abdominis, the obliques. So on those, we can actually, one of the easiest ways to get those is with your patient in the side-lying position. We can use a pincer grip, and pulling up my pen again, we can pinch those muscle fibers together, and then in the side-lying position again, we can needle. It's hard to see this in a three-dimensional view, three-dimensional and a two-dimensional view, but we'll needle through that. We'll thread through that tissue from a posterior to anterior, or if we happen to be on the anterior side, anterior to posterior, just making sure that it's in a tangent to the body as well. We don't want to orient that needle into the visceral compartment. And so there we can catch transversus abdominis, internal, external obliques. So we move from there, we want to look at the fibers of the serratus posterior inferior. And again, we can see the border of that muscle group right here. So anywhere in this vicinity, we can needle. Fairly superficial, probably less than between 2 and 3 centimeters as far as the depth there. And then lastly, we can go after, let me clear, get my pen, let me clear those. So lastly, we can come after QL and psoas. So one of the easier ways, let me hide there. I want you to show you the QL. So here is QL. So you can see the orientation of the fibers of QL. If we take this lateralmost border of Iliocostellus and move further onto the iliac crest, in that window is where we can definitely have our best impact on QL. Now, if I hide that a little bit deeper, then we can see the fibers of psoas. So the way to have a good needle placement here is at the lateral piece of Iliocostellus, just a finger breadth or so further lateral, we'll needle posterior to anterior with some decent depth to make sure that we penetrate into psoas major. It can also be done from the side-lying position, but I like and I prefer to take QL and psoas right here, posterior to anterior. And that would comprise our needling protocol for the thoracolumbar junction.
Okay, and then let's just look at our general thoracic pain, just diffuse, non-defined.
When dry needling for general thoracic pain, the protocol begins patient in the prone position. Our target structures are the erector spinae group, and then electrical stimulation can be offered up to 20 minutes, a burst frequency of 3 up to 100 hertz. Our initial primary locations will be the thoracic spinous process segmentally, in that we get a deep number of structures all the way through down to and including the multifidus. Also Iliocostellus and Longissimus thoracis. And so here we have the Longissimus, and then further laterally is the Iliocostellus. More midline structures, the spinalis, we will, as we dry needle through lateral or adjacent to the spinous process, those structures will be targeted there. We further go into our secondary locations, and here we'll look generally at the scapulothoracic protocol as well as the cervical protocols. Don't want to exclude more lateral and more proximal structures as well. And then finally, our tertiary locations would be onto the ribs themselves. Extreme caution has to be taken. If if the rib and intercostal space cannot be palpated and definitely identified, then you definitely want to stay away from ribs. Again, this is one of the precautions to avoid pneumothorax. Okay, so the dry needling protocol for the thoracic spine. Who would this be appropriate for? Well, let's be honest, it's anywhere that's mainly isolated between T1 and T12. Rarely do we have just a true thoracic issue. If we do, odds are it's going to be parascapular, midscapular, in around the T6, T7 area. But anybody that has that discomfort without issues up into the cervical or down to the lumbar region would be appropriate here. Our position is going to be prone. Our target structures will be the erector spinae group. Our primary locations are going to be the thoracic spinous process segmentally. Here that's going to be your multifidus, and then you move a little further laterally, we'll catch Iliocostellus and Longissimus. Our secondary locations will be the scapulothoracic and the cervical protocol, so those will be represented up a little bit higher. And then tertiary locations is out onto the ribs. Caution there we'll talk about momentarily. Let me move this out of the way. Let me get our specimen in place. So let me remove QL there. All right, we're done. All right, so let's come up a little bit here, and I'm going to go ahead and take out the there we go, the trap, so we can see what's happening here. Okay, so first, the thoracic, here we'll look at the spinous processes, and what we're looking at here is the multifidus. So if you recall, multifidus in the thoracic spine is going to sit a little bit more medial as Longissimus and Iliocostellus are starting to veer a little bit to a more of a lateral approach. So multifidus will be needled independently here. Yes, we will needle in through some other structures, like here, rhomboids. Lower, we'll get into the traps, serratus posterior, inferior, other structures. But our target at the spinous process, 1 finger breadth lateral, would be our multifidus. We'll look a little bit further lateral, and then we will get into our Longissimus and Iliocostellus. So whereas previously we had been 1 finger breadth lateral to the spinous process, and that can be through any of the segments in the thoracic spine. For the Iliocostellus and Longissimus will be a good bit more lateral, and then our needle will be much more at an oblique angle, coming from lateral to medial. Again, caution here is we don't want to enter into between the ribs, so not too much of an anterior direction as we're going into that muscle. It does get a lot thinner, a lot more superficial than we had down in the low thoracic, say at or the lower lumbar, say at L1, L2. But Iliocostellus Longissimus there. For the clear that pin. For the thoracic spine, most definitely, like I said, it's going to be rare to have an isolated issue there. So a secondary location may be the entire scapulothoracic protocol or the cervical protocol, either of those, which there is a lot of carryover between all of those. So a lot of the points in and around the medial border of the scapula into the rhomboids, serratus posterior, superior, and then that spinous process of C6 down to T4, those locations will definitely, more than likely, play a role. But we finally get into our tertiary position, which would be onto the ribs themselves. And an extreme word of caution, if you cannot with any consistent, let me close that, if you cannot with 100% absolution know that you are on the rib, then you do not need to needle that. What we do not want is a needle to enter into the rib
into the lung field. So if you can palpate 100% certainty that you are on the rib, then you can needle that. My recommendation is get lots of practice before you attempt it, and then you will want to take and identify, place your finger in the intercostal space on either side of the rib, and that should bring that rib space open to where you can palpate there. If necessary, you can have them side bend, collapse away, or open up away and collapse down to identify that. If you're going to do that, use no more than a 1.5 millimeter needle and leave at least a 0.5 millimeter exposed. So again, very big caution on needling to that. That being said, at times we do get some good benefit there. So for our thoracic pain, our dry needling protocol for the thoracic area, that would be the last of our muscles. That's our tertiary of the rib.
Okay, then onto thoracic outlet. I've had better outcomes with thoracic outlet patients since I incorporated dry needling into a manual therapy-based approach. And so this is how we go about our thoracic outlet.
For the thoracic outlet syndrome dry needling protocol, our patient will be in the seated or prone and supine position, patient and clinician preference in that position, and which muscles we're dealing with. Our target structures are going to be the scapular movers, again, electrical stim, up to 20 minutes with a burst frequency 3 to 100 hertz. Our primary structures that we're going to look at will be initially Pectoralis Minor, biceps brachii, short head, and coracobrachialis. Second, we will look at the Serratus Anterior and the upper trapezius. In this side, remove the upper trapezius from the image. And this can be done depending on access. Serratus Anterior can be needled below the axilla on the ribs themselves. If they can be, those structures can be palpable. And then upper traps, obviously, right through here. Serratus anterior can also be needled in the prone position on the anterior surface of the scapula. And then our tertiary locations would be Rhomboid Major and Minor, and then Levator scapulae. And then our spinal segmental locations would be everything from C5 down to T1.
For thoracic outlet, the dry needling protocol position here is going to be seated, can be prone or supine. Seated is probably the easiest. Target structures here are the scapular movers. So who's appropriate here? This is going to be anybody with a postural issue, rounded shoulders, forward head, anybody that's having some radicular, some radiating symptoms out laterally past the acromion, especially if it's past distal to the elbow. Anyone that you suspect may have some impingement, the brachial plexus, as it's coursing through that brachial pathway. Our primary dry needling locations will be the Pec Minor, the short head of the bicep, and the coracobrachialis. The second will be the Serratus Anterior and the upper traps, and then our tertiary will be the rhomboids and the levator scap. We can also look at some proximal spinal segmental locations from C5 all the way down to T1. So let's move from here and take a look at on our model. So our primary locations, we said, would be, let me bring up my pen. Primary would be the Pec Minor, the short head of the bicep, and the coracobrachialis. So Pec Minor, in different ways that we can get to that. We can take a direct, let me close and let me come in a little bit tighter here. So we can needle the Pec Minor just medial to the coracoid. So the coracoid is sitting right here, and so we can needle it medial to that and slightly inferior. So we could needle there. Now you want to be cautious because of, again, the brachial plexus sitting further distal. So you definitely don't want to drop a 6 centimeter needle into that to get to that.
We can also look on our primary location, the short head of the bicep and the coracobrachialis. So they will both sit right here. So a couple that we can catch just right there. If we wanted to, short head, we could catch it further down into the bicep itself, or on the, let me close that out, on the Pec Major, the Pec Minor, if we wanted to take that hand in the axilla approach and then thread across. Let me bring up my pen. Let me clear those. We also have the choice with Pec Minor to needle across those fibers. That can be done there as well. So let me clear that. We'll close. Our secondary location would be the Serratus Anterior and the upper trapezius. For Serratus Anterior, again, we will take a position on the posterior aspect. We'll have them put hand behind back, and our needling will be from a midline to a lateral position. We'll go anterior to the lateral border of the scapula. So we're going to end up, our backdrop will be the anterior surface of the scapula instead of posterior. And then upper traps we can hit. Most common we'll hit it in a single location. There's a trigger point a little bit more proximally, a little bit more distally. You can use multiple needles in there if you want, but upper trap, serratus anterior. On the serratus, if a person is so inclined, they can also come. Obviously, the arm has to be elevated out of the way. If it can be palpated, they can also be needled on the rib cage itself. But usually catching on the posterior aspect is more advantageous. And then finally, our tertiary locations are rhomboids and our levator scap. Again, these are all muscles that are controlling scapular movement, depression, elevation. So we can catch levator, rhomboid, minor, and major. Again, these will be butting up against the medial border of the scapula, and then levator is going to be threading across that muscle. And so those are the dry needling locations for thoracic outlet syndrome.
So lastly, let's move on to our dry needling protocol for our supraclavicular nerves. The supraclavicular nerves, they're the three groups of nerves that arise from C3, C4 via the cervical plexus. They provide sensory innervation of the skin above and below the clavicle. Once they pass through the platysma, the fibers arrange into medial, intermedial, and then lateral. They also innervate part of the SC joint.
Dry needling for the supraclavicular nerves. The supraclavicular nerves are three groups of nerves that arise from C3, C4 nerves via the cervical plexus, and they provide sensory innervation of the skin above and below the clavicle. Once they pass through the platysma, the fibers arrange into medial, intermediate, and lateral. It also innervates part of the sternoclavicular joint. Dry needling position will be seated. We can do either bidirectional or unidirectional rotation for needle manipulation, and electrical stimulation up to 20 minutes with a burst frequency of 2 to 3 up to 100 hertz. Our primary neural locations, first in the lateral third of the upper trapezius, then inferior to the clavicle in the anterior deltoid, and inferior to the clavicle in the clavicular portion of Pectoralis Major. Needle length here will be 1.5 centimeters. For our secondary muscular locations, we'll dry needle into splenia cervicis and splenia capitis with a needle length there of 3 centimeters. And then finally, our proximal spinal segmental locations will be C3 and C4. For the perineural protocol for the supraclavicular nerves, the supraclavicular nerves, three groups of nerves that arise from C3, 4, and via the cervical plexus, and they provide sensory innervation of the skin above and below the clavicle. Once they pass through the platysma, the fibers arrange into medial, intermediate, and then lateral. It also innervates parts of the sternoclavicular joint, C4. Our treatment patient will be in the seated position. We can do some needle manipulation if we so choose. And let me move that and bring our model up so that we can talk about the procedure. All right, so the supraclavicular nerve, first off, we're going to see that it is traveling out, again, between C3 and C4. And these are the nerve bundles as they come out onto the upper trapezius. Then you see, and that's the more of the posterior fibers, the lateral coming up more onto the anterior delt, and then on the last branch down onto the Pec Major itself. So for dry needling here, if a person does have some sensory changes in the supraclavicular, infraclavicular, upper pectoral region, supraclavicular perineural protocol may be appropriate here. So our primary neural locations, first is going to be, bring up my pen, in the lateral third of the upper trapezius. So as this nerve moves lateral from the platysma onto the upper trap, we can needle out into this area. We can do one, we can do multiple needles if we so choose along this area. Again, we want to keep in mind the location of the lung field and make sure that we stay superior to that. So any needle angulation would have to be respectful of that lung field. So additionally, we would also look at, let me close that and do a little rotation. We would also want to look at, bring that in, grab my pen. Inferior to the clavicle in the anterior deltoid. So we see that this branch of the nerve crosses over the clavicle at the lateral third, and so we would want to drop needle here, and then just a little bit medial to the AC joint, drop a needle distal to or inferior to the clavicle there as well. And then finally, we would drop another needle into the medial half of the clavicle into the fibers of the Pec Major, anywhere in this general vicinity. Again, want to keep in mind the orientation of the needle and the penetration depth. These would be very superficial. You might use a 1.5 centimeter needle with leaving probably half a centimeter exposed. That way you can respect the lung field posteriorly. So here are our primary neural dry needling locations. Lateral third of the upper trap, into the anterior delt, and into the clavicular fibers of the Pec Major. So we'll clear that. Okay. Secondary, our muscular locations. Oh, let me clear and close. All right, our secondary. So we want to look at where this nerve exits. And so the easiest thing for us to do is come into our splenius cervicis, splenius capitis, and we can drop our needle here. This will be a little bit more anterior of a needle placement. But here we can catch these in this area. And again, that nerve is going to bisect those muscles and a potential area for entrapment. Let me undo that. Well, actually, let me close and then come around. This could also be needled at the spinous process of, say it with me, C6 and T4. And that would get that neuromuscular release that we're looking for in those structures. And then finally, we could also just come up segmentally into C3, C4. So we know C2 is going to, or C1 is going to sit right here, C2 right below it. And so C3 and C4 being the segments of supraclavicular nerve innervation. And so that is the perineural protocol for the supraclavicular nerves.
Okay, so take-home message is when I tell you that it's going to be a shorter than normal lecture module, probably don't listen to me. So we're at a little over 2 hours and 10 minutes right now, but that concludes our advanced thoracic component. A lot of information in there. Again, there's a lot to try to remember. Do yourself a favor, use that app. Keep that readily available if you're in clinic and you're seeing something that's going on. You think this might work, drill through that app. If you have suggestions or recommendations on that, just let me know. But for our post-module assignment, I want to submit a sample 3KS video that includes the following. The cervical linear motion times 5 repetitions, cervical diagonal rotation times 5 reps to each side, trunk rotation times 5 reps, a lumbar linear motion times 5 reps, and then lumbar diagonal rotation times 5 reps on each side. And if you will, go ahead and submit a brief description of what your analysis is of the 3KS cervical screen. So that concludes Module 6, Advanced Thoracic. Our next module, which is in 2 weeks, will be the Advanced Lumbar and Sacroiliac Joint. So look forward to seeing your responses, your post-module assignment results on the dry needling arena. If you have any questions, again, feel free to reach out, let me know, and I will answer as very best and quickly as I can. Otherwise, we'll see you again in 2 weeks.